Good afternoon. This is Derek Olson, the president of WorldOregon, and thank you for joining us for this webinar with Medical Teams International, connecting the local to the global in a time of crisis. If you haven't joined us for a WorldOregon webinar before, welcome. These are free for members of WorldOregon, and if you're not a member, I encourage you to consider joining afterwards to help support our work. We are thrilled to be partnering with Medical Teams International, who we've done several programs before in the past, and we'll talk a little bit more about that. This program is being recorded and will later be posted on our YouTube channel for those who are not able to listen to it live. You, as a participant, are muted with your video off since it's a webinar, and so the only ones with their video and audio on are WorldOregon staff and our presenters from Medical Teams International. Should you wish to raise a question for our presenters, you can do so through the Q&A function. We will also sometimes post in the chat function links to things the speakers may refer to. So now we have the ground rules down. Again, thank you for joining us for this event. Tigard-based humanitarian relief organization, Medical Teams International, is known internationally and locally for their dedication to refugee health care, disaster relief, and mobile dental programs. And we're going to talk with some folks right here that we've worked with, including Joe DiCarlo, who in particular we know well because he sits on our board of advisors, about how Medical Teams International has pivoted with the rise of COVID-19 to address innovative approaches to rural public health in Oregon and Washington and across the globe, particularly in places like Bangladesh and Guatemala. I'm going to do a short introduction of our speakers, and then we're going to turn it over to Medical Teams International to talk about what they're doing. In about a half an hour or so, we'll start Q&A moderated by our Director of Programs at WorldOregon, Tim DeRoche, who you'll hear just audio from. So again, please start putting your questions into the Q&A function, and Tim will moderate those when the time comes. We have three presenters. Our first that I will introduce is Betsy Baldwin, who's the Director of Humanitarian Response Team at Medical Teams International. She joined the organization in June 2018 amidst the Rohingya refugee response in Bangladesh, where Medical Teams International was providing clinical and community support in health areas in the refugee camp through 5 clinics. Her and her team of 7 staff lead medical team analysis, preparation, planning, and response to humanitarian crises globally. She's been working in the humanitarian field since 2007, when she started as an intern in the Darfur region of Sudan. It's a challenging place to start as an intern. She spent over 6.5 years on humanitarian aid programs in Afghanistan, Haiti, South Sudan, Iraq, and the Democratic Republic of Congo. Between these assignments, she spent 4.5 years in program management roles in the United States at World Vision and Salvation Army, supporting crises across the world. Prior to working Medical Teams International, she was the response director for Tear Fund in Iraq, helping those displaced from Mosul between 2016 and 2018. She has a bachelor's and master's in civil engineering with a focus on water treatment and lives in Washington, D.C. The next speaker I'll introduce is Cindy Breilh. She's executive director of U.S. programs and began her career as a nurse entrepreneur, owning a small nursing education business and working in the clinical research for a medical device software startup. She has years of experience working with nonprofits, building high-functioning teams, fundraising, developing strategies, and supporting systems. She's been with Medical Teams International since 2015 as a director of advancement, leading the philanthropy team supporting both U.S. and global programs. She has a rare combination of healthcare management and fundraising to lead the U.S.-based mobile clinic. And having lived in Africa and worked for several international organizations in relation development, she has a deep passion for serving vulnerable populations. In her new role, she brings all this experience to the U.S. programs and addressing dental and other healthcare needs of people in our very own communities. And last but definitely not least is Joe DiCarlo, who, as I mentioned, is on our board of advisors. Joe is Medical Teams International's global ambassador. When Hurricane Mitch barreled through Central America in 1998, Joe mobilized a team of medical professionals to help suffering families recover. This was his first assignment, responding to the second deadliest hurricane in recorded history. And over the course of 2 decades at Medical Teams International, Joe has led dozens of disaster responses. Seeing the suffering on a mother's face is what drives him to help Medical Teams International implement programs that provide for the whole person. He currently serves as Medical Teams Global Ambassador, building faith partnerships both domestically and internationally, and providing duty of care service for staff. Joe, it's wonderful to have you and your colleagues here. And without further ado, I'm going to pass the mic to you to talk about MTI's work in these challenging times of COVID.
Thank you, Derek. And it's such a privilege to be partnering with WorldOregon, an organization I value highly and highly recommend. I just want to give a bit of an overview of Medical Teams just to get us started. You know, we are an organization that was founded in 1979 by a businessman from Salem, Oregon, Ron Post, who was watching the local news on TV, and he saw a story about the killing fields in Cambodia and the refugees fleeing into neighboring Thailand. And here's the important thing. He not only watched, but he acted. He was determined to do something and organized a medical team to provide medical care in the refugee camps in Thailand. And that's how Medical Teams was birthed, so to speak. It's the story of the power of one person. And I'll tell you, that example of stop being an observer or a witness to what's going on in the world and to be someone who takes action is just as relevant, if not more today, than it was in 1979. At Medical Teams, we have a three-pronged strategy in terms of health programming, both here at home and around the world. The first is that we provide direct medical care in a disaster, whether it's natural or man-made. In a sudden onset disaster like an earthquake or typhoon or war, people in crisis are dying from preventable diseases. So we provide direct medical care to people in crisis like that. And in the U.S., particularly Washington and Oregon, we provide direct dental care to people in crisis who have no access to dental services. So that's the first one, direct care. The second prong of our three-approach strategy is community system strengthening. We also harness the strengths of the community to improve health through health education in a refugee camp or an impoverished community. This also includes working with faith leaders to break down cultural and religious barriers to health for women and children, which is frequently the case. And then thirdly, we provide health system strengthening. We make sure that health facilities in the areas where we're working have the right equipment, the supplies, and the medicine they need. We build those connections and we build trust with the health systems so that they will thrive when we are long gone. As you've already heard, we work in the U.S., so Cindy is leading our U.S. programs in Washington and Oregon, and we provide dental care to those without access to care. And she's implementing and considering a Care and Connect strategy to include medical screenings and referrals to partners. And on the global program side, Betsy, as has been introduced, provides healthcare programming in places like Guatemala and Liberia, and in refugee camps or refugee settlements in Colombia, Lebanon, Bangladesh, Uganda, and Tanzania. That's what we were doing as of March 1st, 2020. And then there was COVID. And I think that's all I need to say.
That's great. Thanks, Joe. This is Tim DeRoche, Director of Programs for WorldOregon. I think what we'd like to do is we really want to thread the international and the local connection. And I want to start out there with the international and maybe paint a picture of what has been to be effective at a time like this. How have you been flexible in either converting or expanding your work? Maybe you can talk a little bit about the work in Bangladesh with the Rohingya refugee camp, and maybe move into what the challenges have been with lockdowns in Colombia and Guatemala, and how that's either creating challenges or new opportunities.
Sure, happy to speak to that, Tim, and good to be with you all today. Medical Teams' work in Bangladesh began about 2 years ago, and we've been a primary healthcare provider in that camp since then. As was mentioned in the introduction, And when COVID struck, we, in collaboration with the UN High Commission for Refugees, began some of the scenario planning around what would the needs of the Rohingya refugees be in the event that the outbreak became quite large in that camp. The camp itself is what is deemed as potentially the largest refugee camp in the world. It has about 900,000 people in it. And we serve directly the healthcare for about 50 or 60,000 people. We actually took one of our primary healthcare clinics and closed it for a number of weeks earlier in the spring, and then converted that with the help of the UN into a 50-bed isolation and treatment center, and then began scaling up our staff and training them on COVID treatment protocols, which it took quite a bit of work even to develop a protocol. The treatment and isolation procedures for a low resource context where you're not able to intubate and put people on ventilators is a bit different than what you can imagine here in the United States. And so looking at what medicines we have access to help people breathe well, and what just basic techniques and things like having our patients lay on their side for a while and then lay on their stomach just to keep their airways open. And then all of the referral protocols upwards have been some of the things we've done in Bangladesh. And then just looking at how do we just continue to encourage staff on the technical front and just support them as well as we can as we've adapted and grown that program to include that COVID isolation and treatment center. As you mentioned, Colombia and Guatemala are two other interesting contexts. Colombia, we're actually in a startup phase and have been since late last year. And we were about to implement some programming specifically designed at allowing Venezuelans to access primary health care. It seems like a really basic and simple thing, but most Venezuelans, about 80%, are marginalized outside of the primary healthcare system in Colombia. And so they have to wait until they have an emergency health condition in order to be seen in the ER. And frankly, many people aren't able to easily get into an ER just due to high demand on that healthcare system and concerns about the cost of the 2 million Venezuelans in Colombia and the demand on that healthcare system. We're actually in the process of adapting and identifying the Venezuelans in our target community. We work in a place called Santa Marta, which is kind of on the northern coast of Colombia, and looking at how we can make sure people have messages about how to prevent the spread of COVID. What is it? I'm sure a lot of you have heard the phrase, this has been referred to as an infodemic. There's lots of bad information and new information evolving, a lot of uncertainty and a lot of fear. So getting people information, but also getting them into the healthcare system, realizing no matter if you're a refugee in Bangladesh or Colombia, or you're living in Guatemala, you still might have a cough and cold that might not even be COVID, or you might have a child that was born last year that needs their essential vaccinations completed so they're protected from vaccine preventable diseases. Just to then speak briefly about Guatemala, we've had some really interesting opportunities there. We work in the Central Highlands, primarily through community health work, but had quickly adapted that in January and February, just through the quick thinking and innovation of our staff there and working closely with local health authorities to train them on identifying COVID in their environment, and then using community structures to implement surveillance and help people identify when they might have a family member or neighbor who has been affected by COVID, and ensuring they had adequate, safe water to implement good hygiene practices in their households so as to limit transmission. And then on top of that, we were able to, in conversations with the U.S. government, expand that program in our indigenous communities in that Central Highlands area down into one of the hotspots of COVID in Guatemala, into some of the urban slum areas where people are continuing to, they're not able to enter lockdown and they have to continue to work to feed their families. Seen an uptick of cases. So we'll be working, actually we started earlier this month working with the Ministry of Health to build their understanding of, again, similar things, case identification, knowing if someone has COVID, how to treat that, and then how to help them when they return home, or if they're implementing a home-based care protocol, just how to protect other family members and make sure that if their case does become severe, they know how to get higher level care. So those are just a couple of examples of how we've adapted our programming. I'm happy to take more questions. Thanks, Tim.
Sure. In the early days of quarantine, one of the big news stories was the difficulty of procuring PPE supplies. And I'm wondering if you can talk about, what the challenges of that were for staff and protection of staff, and how you're navigating some of this work without international staff support able to travel to where you're working.
Yeah, personal protective equipment is a big issue. Thankfully, as a health implementer, we already have some personal protective equipment in our clinical operations. And then we also have a gift in kind program through generous donors here in the U.S. We were able to ship out some of our personal protective equipment we had into some of our international programs, which was greatly appreciated, not only by our staff, but also by many of our partners and government. In one example, in Guatemala, we were able to support the main field hospital set up in Guatemala City with personal protective equipment back, I believe that was in early March. But we are continuing to work with our logistics team to identify suppliers and work with the UN to make sure we actually have, in some cases like Bangladesh, we want to be extremely cautious and ready and have a 12-month supply of personal protective equipment, just because we don't know what will happen with global supply chains in the forthcoming months. And then also too, we don't know our caseload and our consumption of that personal protective equipment in the coming months. So we want to be very conservative on how we're planning for that, but also realizing the need for personal protective equipment while people are in the office or out in communities interacting, or even just driving an ambulance and making sure our ambulance drivers are safe. You mentioned something else after PPE. Remind me what you said, Tim.
The challenges without international staff support.
Oh, right. Yeah, and we've tried to adapt our headquarters support. A good example of that is our lead senior medical advisor has been having Wednesday morning case reviews with our Bangladesh team as we've had patients come into our COVID isolation ward. She's actually an ER doctor in Indianapolis, and then able just to continue to work with the team and have them identify what are the areas they feel like they need additional support or training on, and then just reviewing complex cases. We had a very complex case, just to give a brief example of someone with severe diabetes that interfered a lot with COVID. So making sure we have a strong pipeline of just information and relationships to staff, and are just continually available to support them on troubleshooting and on ideas about donors to approach or different ways to solve problems, and work with our other NGO partners and governments to get the care that's needed to those refugee communities.
So you touched on a little bit the adaptation of community health work with technology, with phone messaging and phone calls. Mm-hmm. Has there been a challenge, and have you figured out ways to bridge digital divides, especially when you're in communities of extreme poverty?
Yeah, the good news is most of our communities really have access to cell phones, at least maybe not every adult, but at least every household. So things like WhatsApp groups in Lebanon are very common for passing messages about symptoms of COVID, but then also just digitizing our engagement with communities more to track what households have we visited, which households maybe are expecting to deliver a baby in the coming months, making sure they feel safe in delivering that baby, or are aware of where to go for complications. And then also just through the simple use of phone calls. 2 examples of that is just reaching out to Venezuelans in Colombia via phone call when we can't easily move around their community to understand their situation, but also to making phone services available for people to call if they think they might have COVID, but need additional information or a bit of diagnosis. We're actually starting a research project with the University of Washington and the Harvard Humanitarian Initiative on a bit of a telemedicine approach to get rapid information and sort of triage potential cases in places like Uganda.
So with the Rohingya situation, one of the challenges here is the refugees are coming out of a severely conflicted and polarizing battle, in essence, between sort of faith and ideology. Is there a challenge as a faith-based organization in navigating some of the complexity and the dynamics of that?
Yeah, I think there are always challenges as we try to understand local culture, context, and religion. But I think in my experience working in the Middle East, working in sub-Saharan Africa, being a person of faith is much easier for people to understand when compared to if you context and say, oh, I don't have any faith. So I think we've had lots of opportunities, and through Joe's work, using channels of hope, interacting with faith leaders and then finding commonalities around human dignity and other messages to incorporate into encouraging good health-seeking behavior, caring for children well, and caring for your community. I think there's a lot of commonalities that we can come together regardless of the religious community of the persons that we're working with. So it is often a bridging function, but I'm sure Joe can speak to that more as well in his work.
So in terms of the international and the U.S., do you have a sort of a feedback loop of best practices of what the U.S. programs can learn from the international and vice versa?
Yeah, I mean, I'll mention a couple of things. I'm sure Cindy has some more as well, but one example is our environments, both in the U.S. and internationally, are complex. We've seen crime and just general insecurity increase internationally across the work of humanitarian NGOs globally, and have really had to strengthen some of our security and safety management systems. But then also we've been sharing some of that with Cindy's group as she works in a variety of urban areas. And this work often pulls you into new places and new neighborhoods that you may not know as well, and using good tools to assess that and build acceptance with the community so they know who medical teams are. And when they have a question or a concern, or maybe there's a false rumor about what we're doing, we want to be able to be in touch with those community leaders quickly just to make sure we can clarify and just reconfirm with them if they're happy for us to continue working. We also work with a couple of doctors who work both in the greater Seattle area, and just sharing on protocols and even just approaches on how to set up things to make sure patients can safely transmit through. Those are just a couple things that come to mind on that front.
Well, that seems like a really good segue. So let me pivot to the U.S. and talk about how with COVID, how you've accelerated your Care and Connect strategy to move and basically build upon, your traditional program like your free dental care program, and sort of where you're at with that and where you're working.
Great question. Thank you, Tim. And thanks to Betsy for that great information. Yes, so many people may know of us in the U.S. context as a mobile dental program. And actually 30 years ago, we did get our start with medical and dental together, and then morphed into more of a dental model because we felt that was the big healthcare gap not covered by governmental services. But more recently, we've begun to realize we shouldn't just see our patient encounters as a single service encounter, but begin to see our patients more holistically, because many of them have multiple problems. As one of our dentists, our volunteer dentists, said, when patients come on, the dental problem may be number 5 of 10 different problems that they're experiencing, and what else can we do for vulnerable populations? So that work began about a year ago to figure out what would be an approach, and that's what you referred to, Tim, as our Care and Connect approach, where we said, let's not just do this dental care outside of the traditional safety net system in our own communities, but let's get with our community safety net providers, and let's add to their knowledge of the patients we're serving, and then what else can we do? And so we talked to them about additional services, including some medical screening services, chronic illness kinds of things. There's a whole host of opportunities. One thing that came up, which is really interesting, we can talk about later, is vaccinations was already on the table. So we were slowly moving in that direction and really thinking about where are we going to start implementing and adding services to our dental program. And then COVID came. And so what we did is we worked with our medical advisors to say, what is it that we can do? So we first changed up how we provide medical care so it could be appropriate in a COVID environment, which, believe me, was a huge shift. And I think that as of today, everything that I know of, there's no other mobile fleet in the United States providing dental care that continued during the early stages of COVID. I think that many of them are just getting back on the road now in June. But again, because of our DNA in the organization, our agility, our understanding of disasters, we quickly got to work with our medical advisor and really figured out how we could safely continue dental care under CDC guidelines, American Dental Association guidelines, keeping our staff, our volunteers, and our patients all safe. So that was our first pivot. And then we began to get requests from different agencies. Could we help with mobile COVID testing? And because we have these 38-foot long dental offices that have Wi-Fi, heat, refrigeration, a great setup. Even though you're doing the testing outside, they're a great sort of administrative office you can take on the road. And I kind of went, not going to do testing. We'll support anybody else that does testing. And so we tried that for about a month. And then we got requested again by one of the hospital systems, could you take over our mobile testing? And so we crosswalked with them through the entire process and felt like, yeah, we can do one more pivot and help with COVID testing. And we started in King County, which many in Seattle area, which was sort of this epicenter for the United States, or at least one of the epicenters. And then the state of Washington heard about what we were doing and asked if we could add capacity in Eastern Washington, which is where I'm at right now in Yakima County, right in the center of Eastern Washington, which is probably similar to Eastern Oregon, a very rural community, under-resourced. 63% of the population here are essential workers, many of them Spanish speakers. So we're actually, delving into our volunteers and staff who are bilingual, which is incredibly helpful. And so we've begun this rural COVID testing program, and we have 2 teams, hopefully soon to be 3 teams of testers here. And it's an absolutely fascinating environment that we're working in. One of the scary things here, although the curve is coming down, thankfully, but there was very slow uptake on all of the public health messaging around masking and hygiene and social distancing, not a lot of belief. So here we go into our international work of cultural competencies and understanding the culture that we're actually working in, not just from a language, but what are the beliefs of the people that are here. And even while we've been here, we've seen a transition and it's so much more acceptance around testing and around public health measures to stay healthy and safe. There are pockets here, believe it or not, where the prevalence is about 90%. And these are the places that the state is asking us to be very active in, because that's a disaster. And how can we help through aggressive testing, block and contain pockets of outbreak. We're working with the Yakima Nation as well, and migrant workers, which I think the population here swells by 20 to 30,000 every year at this time. And these people migrate through several states during harvest, and the concern is carrying the virus with them. Lots we've learned, again, cultural context. If farmers don't have workers, we don't get food on our table. And if workers don't get to be out in the fields and have to quarantine, they don't get their livelihoods. And so we're also out here with a double-edged sword of how do we sit in the middle there and be a safe place to do testing. So I'll stop there, and Tim, you probably have other questions for me.
Well, you brought up an interesting point. I mean, prior to COVID, I think one of the hurdles for anyone working in public health is there is a significant anti-vax movement. And has this been, has it been exacerbated by COVID? Are people more amenable to changing their minds or expanding the sort of knowledge related to infectious disease?
That's an excellent question. And I don't claim to be any expert on it. I'm just the reading that I'm doing. I think there will remain about a 20% of the population that will not be interested in the COVID vaccine once we get it. I think that there are just people who aren't probably going to change their minds on that. But we're going to get into that, because I'm hoping that once we get through this COVID testing cycle, which probably will be going on through at least the early next year, that we'll begin to move into doing vaccinations and be part of a strategy with local jurisdictions around getting vaccinations broadly available, especially to vulnerable populations. So I'm only guessing on that, Tim. I think it's not changing particularly, but I do know there are people who are very anxious and do want the vaccine as soon as possible.
Great. One of the things I think that, I've read a little bit about it, but I think we're all very implicitly, if not explicitly, aware of the challenges this moment has put on us as individuals, communities, and cultures: isolation, kids not being able to be in school. And Joe brought up a great point, and I want to bring Joe back in to really talk about the question of self-care. I mean, we certainly at WorldOregon, we think a lot about this as an organization. How do we move through this and make sure that we're taking care of each other? And I'd love to hear sort of what the strategies are within Medical Teams International. And then after that, we'll go to Q&A. We're getting some really good questions here.
Okay. Thanks, Tim. First of all, I just want to say, when the organization decided to go into lockdown, and we did that about a week before the governor announced it. So we've been around lockdown around 17 weeks now. We had the capacity in order to do it well. We already have been working remotely, in a sense, with our field programs overseas, our staff overseas. We've had electronic financial reporting, financial approvals were all electronic, paperless. And so we were in a good position to just allow limited number of staff, office-dependent staff in the building. But how do you, after so many weeks of this, how do we maintain a sense of connectedness and a sense of common mission when we're never together? And that's just the U.S. side. Then you think about countries like Uganda that went to serious lockdown, and some of our staff, they work during the week, which is very typical, in the refugee camp, and then they travel home on the weekends, and they were unable to travel home. And so they're stuck in the camps. And in some cases, as Betsy said, we couldn't send additional staff to Bangladesh. And so we would have staff who were unable to take leave and to have time off. So how do we address these issues? And it really required us to be creative. And some of the important things that we've done, staff care and duty of care has always been important as an organization, but it really brought it to the top priority on several fronts. And one of those fronts was, how do we, information going out regularly and frequently to all staff worldwide about stress management and personal well-being. It was okay to grieve what we lost because of our lockdown. We don't want to deny those feelings because even though others are worse off than us, we still need to make sure that we acknowledge the sense of loss, that we get sleep that we need, the rest, the nutrition, the exercise. These were not things that we had to just take for granted. We had to be very proactive in ensuring that we got them. We had exercise competitions, and each department was required to, each person was asked to log the number of walks or whatever exercise they had done, and then they would go ahead and compete. We had wellness checks and calls. Calls were made to individual staff on both the U.S. program side and on the global side. As Cindy said, they pivoted so many times. Many of the staff didn't sign up for this job that they were doing now. And so how do we help them process through that and see them through it? And then one group even sent care packages to the U.S. staff. That was on the staff care side. Then on the HR, the human resource side, we made sure information was given to the staff about the Emergency Paid Sick Leave and Emergency Family and Medical Leave Act for COVID-related needs, social distancing policies, COVID-19 critical incident and communication protocols, just in case someone comes down with COVID. How do we handle that internally? Working with the country managers and the HR staff in the country offices to provide them support for the unique safety and care needs that they have, and providing guidance to the managers when they ask them, their staff, how are they doing? How do you ask those piercing questions to really get to the heart of the matter and to make sure that they're opening up and feel safe to do so? So those are some of the approaches that we've taken and we continue to use today, and hopefully even after the COVID situation passes, that we'll continue to make these priority issues.
Great. So let's bring Cindy and Betsy back on, and let's move into some of the questions. We're getting some really good questions from attendees. It was great to hear that piece of how you're taking care of each other internally. I think WorldOregon's going to have to implement an exercise contest. That'll be fun. So my first question here is, do you have home care training manuals in either English or Spanish? This person is in Bay Islands, Honduras, and they have their first case after being totally isolated on the island since March, and they need to plan now to train caregivers.
Yeah, I can take a stab at answering that, Tim. We do have a number of home-based care protocols. I know for certain one for Bangladesh, and then also looking for contextualized one for Guatemala. And then at the global level, through groups like the CORE group, which is a group of Alliance of Health NGOs, they've been distributing a lot of that. And then we also work with the Global Health Cluster, which is led by the World Health Organization. So I don't have the links close to hand, but happy to connect people or share those out. I don't know if Cindy, you have anything to add on that?
I don't. I think what you suggested is the best. Yeah. Mm-hmm.
So I just thought of this as you were answering the question. How does our pulling out of the World Health Organization affect the work that you do both domestically and internationally?
I think it's a lagging effect at the moment. I mean, all international organizations and the bodies, the various bodies like UNICEF, the UNHCR, and World Health Organizations run on donations from member states. So I believe for things like this year, the budget is fine, but the size of UN organizations is actually quite volatile based on funding and priorities that are identified by the Secretary General. So we could see a reduction of capacity of the World Health Organization and the UN to support things like we've had them run humanitarian flights, supporting development of protocols for low resource environments, provision of PPE at the global and the local level, and then just even support to the responses that you see like in Bangladesh. So I think it'll be a lagging factor, and our response mechanisms will have to adapt around that, but undoubtedly there will be likely an impact.
Okay, Got a question here from Buck. He writes, our agency has pivoted to address a void of healthcare of tribal residents along the Columbia River. And we've partnered with One Community Health to provide COVID testing to both the tribal and non-tribal community. To target the tribal residents more, it has come to their attention that they need a mobile medical unit to be able to get to them along the fishing access sites where they camp or live. Does anyone have any advice on how to attain these units? They have received CDC and Oregon Health Authority funding or grants.
Yeah, is a great question, Buck. Interestingly, we actually have been requested by the Washington Department of Health to do mobile testing with those communities, those fishing communities. So I'm wondering if it's going to go over into Oregon as well, because it's right along the river there. And perhaps we can connect after this call, because I think there's going to be a very large campaign, intensive campaign with partners for the Yakama Nation. And then they're going to be using medical teams to do the mobile testing with those fishing communities. So it'd be great if we could work on both sides of the river.
So Cindy, maybe you can put your email address in the chat. So if Buck wants to get in touch with you, he can.
I will do that. Yeah.
Next question is a two-part question. A, where does most of your funding come from, and are contributions down because of COVID? And B, do you coordinate with other medical relief organizations so as not to duplicate efforts?
Joe, do you want to take that?
Most of the funding, well, it's two-pronged. So we get institutional funding, U.S. government, UNHCR funding for the international side. And then we also get funding, private donations as well, to supplement the international work that's not covered by the institutional donors, like the UN or government funding. But also on the U.S. side, Cindy's programs and U.S. programs, that is primarily grants from foundations as well as private donations. That's where most of our funding comes from. And the second part, Tim, what was that?
Do you coordinate with other medical relief organizations so as not to duplicate efforts?
Yes, that's an excellent question. And we absolutely do. You know, we're called medical teams. And so we are really, we seek out collaboration. We're part of, on the international side, we're part of an alliance of organizations, the Integral Alliance, and we coordinate activities through that alliance. Betsy already mentioned the core group in terms of standards. And so there are a number of opportunities that we have to work in collaboration. You're right. The worst thing we could do is have a duplication of services. It's a waste of time and resource that could be used elsewhere. And Cindy as well. She's not just going out and sending out these mobile vans on her own. She's coordinating very closely with public health officials in each state and each county. Cindy, you might want to share more about that.
Yeah, I would just affirm that. I'd say I have never seen so much collaboration and cooperation between agencies as we're seeing right now. And so, you know, necessity is the mother of invention, right? And we are so also resource constrained that it's forcing us to really work together and collaborate. And it's showing gaps in our healthcare system and lack of coordination and lack of communication, and that we need some better systems in our own healthcare.
So here's a good one. To what extent has the current U.S. administration affected your work?
Do you want me to start off? I can make just a couple.
Jump in.
Okay. Well, clearly the lack of resource, starting with the PPE at the very beginning of this COVID crisis, and then sort of the lack of coordination on the testing side, I see that. And I see that as a real gap that we have. And it's a shame, because here we are, such a rich country, And we're doing such a poor job of managing this pandemic. And, you know, as Betsy is, we're all watching the PPE shortages that are probably going to continue globally down the road. And we certainly, I feel that the administration, certainly at the federal level, has been inadequate in this response. So.
I would say too that the mixed messages that we're hearing from administration officials about safety and the importance of masks, this is all causing confusion and division among on the ground, you know, and the people that we're seeing. And so, that has really impacted us in quite a negative way.
Mm-hmm. Yeah.
So I'm wondering if you foresee the COVID testing model moving internationally, and if so, where?
Yeah, that's a great question. I foresee us continuing to coordinate with ministries of health to make sure testing access is in place. And if, for example, in Bangladesh, we take a lot of samples at our clinics for suspected cases and then pass those off to a larger health coordination system. So I foresee the access and the encouragement of testing capacity and encouraging people that testing is safe, it's very quick, and encouraging people to get a test when they think they might have been exposed or are experiencing symptoms so that they can take appropriate actions to seek care and isolate themselves. So I think that's going to be an ongoing theme of making sure there's equitable access to testing regardless of the ethnicity of the person, the location of the outbreak, or anything. We want to continue to be that voice to make sure people have appropriate access.
Tim, if I could add to, it's really interesting, you know, when we're looking at the local and the global connections, we now are developing a common language. In the US, we never really talked about contact tracing before. It wasn't something that we even thought about. And yet when I was talking to some of our field staff in Uganda not long ago and said, yeah, we're not used to contact tracing. They said, you're kidding, because you're the ones who taught us contact tracing over the years. You know, they're very good at it in Uganda. There are very few deaths and very few cases in Uganda of COVID because of their experience with other pandemic and other infectious diseases. And so one of those connection points has been, now we have a common understanding and a common language about what it means to deal with pandemic and and contact tracing in particular.
So here's another question. This is from Carolyn. How do you recruit medical personnel, both stateside and abroad?
You want to start, Betsy?
Sure, I can just give a couple examples. For one in particular, in setting up our isolation and treatment center in Bangladesh, we identified the need for an infection prevention and control specialist. So we advertised that just like any other job on our website, took applications, and then shortlisted those, and then had a series of interviews with our medical advisor and with our field team just to determine fit, capability, et cetera. And that's pretty common process we use for even local clinicians, just through general job advertisement, experience, vetting, et cetera. Cindy, things to add to that on your side?
Same kind of thing. However, we do use a lot of volunteer providers. That's what's enabled our programming over the years. So we do a lot of recruiting. Maybe it's not the best, but we try to invite people to come join us for temporary positions, or sometimes it's even a day. Right now we're doing 4 days at a time in different locations. So we look to all kinds of people, including, you know, who's been a fantastic resource recently has been the public health reserves. The states have volunteer medical people that are willing to serve. So we're tapping into those places. We tap into other medical centers. So we try lots of different things to get both volunteers and staff with us. It's not easy right now.
I can imagine. So you're based in Tigard. The Portland region is also home to another humanitarian organization, Mercy Corps. And I'm curious if you could talk about the relationship with them. Is there sharing of best practices? Do you play each other in kickball? Do you find yourself competing for resources, or is there a good sense of collaboration and learning?
Yeah, I can take that. It's interesting. Over the years, we started, actually, the two organizations started around the same time, centered around the Killing Fields disaster tragedy in Cambodia in '79. And over the years, we have collaborated together, and we frequently see that collaboration more in the field. We focus on the health sector, and Mercy Corps focuses on other sectors. And so we're a good complement when it makes sense to collaborate together in a particular disaster. So in my 21 years histories at medical teams, there have been a number of occasions when we've worked together, or even just shared ideas and best practices. And that's been always beneficial.
Great.
Yeah, and just to add to that, Mercy Corps also, I'm actually based in Washington, D.C., and Mercy Corps is a very active collaborator and member at the Interaction Forum. And so we work, closely with them on advocacy issues, most recently even on this pandemic, funding of PPE in the international context, and just encouraging the U.S. government to make award from the congressional allocations for the international response. So they're very active in both the coordination forums globally and, like Joe said, in the local level as well.
Mm-hmm. And maybe from my perspective, I will say that our connection with the Oregon Health Authority and our potential deployment of COVID testing teams in Oregon really came from Mercy Corps and saying, hey, we don't do this. Is this something that you guys could take on? So, yeah.
That's great. So I want to thank all three of you. Joe, I want to bring Derek back in. And Joe, are there any last minute thoughts you'd like to share with us in terms of how you're working and what you're doing right now?
Yes, thank you. I just want to say, if you want to learn more about medical teams, please visit our website at medicalteams.org. You'll get a good menu and complement of activities and more detail on what we've discussed today. And also, starting tomorrow, we're having a special event. It's called the Field of Dreams. It's a virtual event, so feel free to look on our website. And if you want to participate in that, it's very easy to do so. We thank you all for this opportunity just to share about our experiences and the work that we're doing at home and around the world to make things better.
Joe, thanks so much, and thanks to your colleagues. And your work is critical throughout times, but especially with COVID-19, it's even more pressing. And I appreciate your collaboration with other local strong partners like Mercy Corps and WorldOregon. And thank you to the community for supporting you and your work. And we will be doing more programs in the future with Medical Teams International. From time to time, we have been able to host some of their representatives in the field when they've come back from being overseas. So thanks again, everyone, for joining us today. WorldOregon is working on some more webinars. Will be coming up shortly in early August. Tim has a lot of good ones on the burners that are simmering, and we're trying to bring them to a boil ready for you to enjoy. In the meantime, you can also go to our website and our YouTube page to see video recordings of all of our previous programs. Thanks so much for joining us today, and stay healthy. Bye-bye.